Good evening, everyone. Welcome to tonight's episode of The Upside. Our show is about to begin. We want to ask all of you, so you can maximize your experience, we recommend putting your Zoom screen on speaker view. Now, it is my pleasure to introduce your hosts, Beth Goldsmith, Chair-elect of the Associated Federation of Baltimore, and Dr. Scott Rifkin, publisher of JMOR. Beth and Scott, take it away.
Thanks, Jonathan, and welcome again to The Upside. This is our virtual show brought to you by the Associated Jewish Federation of Baltimore and JMOR Magazine to keep our Baltimore Jewish community informed during these uncertain times. We are coming to you twice a week with episodes you can view live on Zoom, Facebook, and YouTube. Each episode tackles some of today's most pressing topics, features some of the community's leading experts, and hopefully answers the questions that are on all our minds. Today, we'll be talking about the evolution and spread of COVID-19. Every time we seem to think we understand the disease, we hear something new. Last week, it was the recognition that the disturbing symptoms of heart inflammation in young kids in New York are actually symptoms of the coronavirus. This week, we learned that the recovered sailors on the Navy ship tested positive again. So what do we need to know about COVID-19, and what do we still have to learn? What should we expect about how the disease will evolve and spread in the next weeks and months? Scott, please introduce our guest.
Thanks, Beth. On behalf of the Associated and JMOR, we're thrilled to welcome Dr. Eili Klein. And Dr. Klein, if I pronounced your first name wrong, please correct me, to the show. Dr. Klein is an assistant professor of emergency medicine, an epidemiologist at Johns Hopkins Medicine, and an expert on infectious disease dynamics. And I took a minute to look up Dr. Klein's background, and he went to 3 schools, none of which would have me, okay? Just to give you a little background. He did his undergrad at Columbia University. He did his master's at Johns Hopkins, and he did a PhD at Princeton. And I am 100% sure not one of those 3 institutions would have considered me as an eligible candidate. So thank you, Dr. Klein, for being here. Let me start you off with a first question. Tell us what you do. Tell us about the work that you do.
Sure. Thanks, Scott. And yes, you actually, unlike most people, did pronounce my name correctly the first time. And while I did go to some, I guess, nice schools, my mother's still disappointed I didn't go to Harvard. So, you know, everybody. Yeah, so I just wanted to, I work at Johns Hopkins. I'm an epidemiologist, and I'm also a senior fellow at the Center for Disease Dynamics, Economics, and Policy. For the last 15-something plus years, I've been working on the spread of infectious diseases. And my focus is largely on how what we call economic epidemiology, and not economics the way we typically think about it in terms of how money works and finance works, but economics actually has a lot to say about how people behave, and how, and this sort of time period, the effects of how people behave is actually what is driving a lot of what is going on in terms of the spread and what is going to happen with the spread. So that's largely what I do, and most of my work is involved around modeling how the disease is likely to spread and providing planning purposes for and scenarios for the state of Maryland as well as for Johns Hopkins.
Very good, very good. So I've got 1,000 questions, but we're going to go with Beth. Beth, why don't you start off with another question?
Well, I'd like to start with something I mentioned in the introduction. It seems we're consistently hearing about new symptoms of COVID-19. Is that because the disease is actually mutating, or is it that we didn't put 2 and 2 together from the beginning? What are we missing?
So, I mean, I don't think that the disease is mutating. I think the best evidence is that it's actually not mutating very quickly, which is a positive, because that means that there's more possibility that a vaccine will be effective and be useful when it's developed. That said, the problem is that we're getting more and more people who are actually getting infected. So I believe the latest number is at 5 million. That's the number that's actually confirmed. The number has gone, that's probably only the tip of the iceberg. There's probably several million more people who have been infected. And the more people that get infected, the more chance there is for some sort of weird thing to show up, right? And so we're seeing a lot of these sort of abnormal type things, and they're making a lot of news, but they're probably the very small minority of cases. So I recognize that the issues around the kids and the Kawasaki syndrome-like illness is a serious, worrisome point for parents. And I have a 7 or an 8. I guess she's 8 now, 8 and 10, and they, it's obviously worrisome. But given the number of people who have actually been infected, this is still a very, very rare thing. And so most of these other syndromes that we're seeing are probably, there may or may not have been some in the early effects that happen, but things have happened so quickly and there's been very little time to document it. I mean, we're talking about a disease that's been around for 5 months now. So, there's still probably lots of minor variants that we haven't seen. And there's obviously any long-term effects. We don't have any idea what those are going to be.
Very good. So let's talk about modeling for a second. When I turn on CNN, I hear about Hopkins modeling and curves, and I hear about the University of Washington and the Murray model, and my friend Avi Flaxman up in Seattle putting the model together. Talk a little bit about modeling and the limits of it.
Sure. So, I mean, models, the famous phrase in modeling is all models are wrong, but some of them are useful, right? And so the idea is what can models tell us, right? What can they inform us about how things are likely to spread, how and why they've spread the way that they've spread, right? And so there's the first models of actually disease have been around since the early 1900s. And what they can do is they can provide some context and understanding around how things are likely to spread. And so what we're trying to do is look at how things are likely to spread, but also they can be used to understand like how things have spread, right? So we've been trying to understand, given the outcomes that we see and what we know about disease dynamics and how people interact, the likelihood of how many people have actually been infected, right? So estimates of that have varied, and when they finally started doing antibody testing, it was much more than people had initially thought. However, the models that I was running were suggesting that actually there had to have been a large number of people infected in order for us to see the number of cases that we were seeing. So I think modeling can provide a lot of different utilities. It's not it's not a panacea. It's not going to tell us what's going to happen, but it can be useful for planning. It can be useful for understanding what are the likely things that are going to happen. So we use it at the hospital for planning how many more beds are we going to need at what time. And we use it at the state level. So our models help provide guidance to the state on should they consider reopening X, Y, and Z. So what are different scenarios they want to look at? How much contact tracing and quarantining can we do? Given resource constraints, if we do this much, how effective would that be relative to inputting our resources somewhere else? So I think there's a lot of different things that models can do, and there's a lot of different scenarios that we can run that that allow us to think about possible options for dealing with this pandemic.
And I assume they're only as good as the assumptions and people following the assumptions. So if you open the country up earlier, it changes the model.
Right. And so, I mean, one of the big criticisms has been that, the models have been wrong, or the models have been this and that. And the problem is that unlike the weather, where if you forecast it and it goes wrong, somebody gets, that's one thing. But alternatively, if you forecast the weather and the weather doesn't change its behavior based on what the model says, Whereas in this case, the initial models were suggesting large numbers of people were going to be infected and die. And so everybody changed their behavior. And that meant that the models that were predicting based on those assumptions were no longer valid. And you had different assumptions that were then underpinning things. And what we try to do is look at how we've gotten to where we've gotten to now. And given that context, what are different possibilities for the future, right? So we know that people are starting to move more and we're lifting the shelter in place orders. And so what we don't know is how much people are likely to change their behavior and what's the impact of that. And so we're trying to model both what is possible impacts of that and possible changes and open up certain things, what is the likely impact in terms of transmission? And given those different possible trajectories of transmission, what's the likely impact at the hospital level? So all of those things can help sort of feedback to inform people's decision-making process at sort of the policy level, which then some part of it comes back out to the public and informs their decisions, right? So me even coming on here is going to change possibly how somebody behaves in some level, which may or may not impact how well the models work. But the goal is really not, I mean, obviously it's fun to, I guess, on some level to predict what's going to happen, but really the point is to try to put different scenarios together to try to guide better policymaking. So
here's a scenario.
Okay.
What about sending our kids back to college and our younger children back to school? Do you think in the fall we can open safely?
So that's the big one that I've been modeling recently. I mean, obviously predicting something that is 3 months out is difficult. And we still have not yet seen how much of an effect the weather is going to have on this. So historically, respiratory diseases tend to go down in the summer, right? You don't generally tend to have a lot of people with flu in the summer, and you generally don't happen to have a lot of people who get respiratory viruses in the summer. They don't go away completely, but you don't have a lot of them. And there's possible reasons why that is and why that isn't. And the evidence historically from pandemics is mixed. In the 2009 pandemic, flu kind of came and then went and then came back again in the fall. In the 1918 one, it seems to not have gone away nearly as much. So we don't really know what's going to be the effect on that, right? And the reason I bring that up is because the big issue with opening anything is how many people have already been infected, right? So that's, the more people that have been infected, the slower it's going to spread and the fewer people that'll be infected at any one time going forward, right? And so if you're worried about a big, huge surge of cases that could overwhelm the healthcare system, then if you have a lot of people infected at any one time, then that's what you're worried about. And the more people who are susceptible at any one time, the more likely that surge is. And so it kind of depends a little bit what's going to happen this summer. So as people open up and we have more infections, because most likely that's what will happen, that we could potentially keep things at a level that will allow there to not be a huge surge in the fall. On the other hand, if seasonality sort of kicks things down, or we keep the numbers of susceptible people high because we keep social distancing all the way through the summer, and people only slowly change their behavior, then opening the schools could lead to a big increase. And again, part of the problem is we don't know how transmissible the kids are. We know that they don't tend to get sick at the same rates that everyone else does. I understand there's the Kawasaki disease, but again, relative to the rates in older adults and particularly in very old adults, the rates of hospitalization and severe illness in children is very, very low, which is obviously very different than the flu and different than other respiratory diseases. And so why that is, we don't know. And we don't really know if that means that they are significant vectors for the disease. So if we open the schools, will they go back to school and then bring it home to their parents and get their parents sick? Or will they, get minor sicknesses at school, but not be a big problem on a society level, right? So that's sort of the problem. But the modeling right now that we're doing is suggesting that, so one of the big things that happened, with the lockdowns was when the models we showed suggested that closing the schools would only have a moderate effect if you didn't close everything else out. And most of the models said that. But the problem is that the reverse isn't true. Opening the schools actually has a really big effect if people are still social distancing, because again, it really comes down to what does it mean to open the schools, right? So if we open the schools the way they would normally run, we know most kids, particularly the younger ones, are not particularly good at social distancing and or washing their hands and or they are very good at being germ factories and bringing disease home. So I imagine that whatever the consideration is, they probably won't open with like letting everybody go back to the normal. So assuming people don't go back to 100% normal, how far from normal do we need to be in order to keep it from being a surge? That's really the question, I think, what people are going to be asking. Does that make more sense?
Yes, thank you. I get it. It's very complicated.
Well, it's very complicated, but I think the real difficulty is saying, well, we know we have to have some precautions in place. What is the level of those precautions that we need to have in place in order to have schools open and be a safe environment, both for the kids and for the society at large, right? So that's sort of a dual tension. Understanding, of course, that, you know, when we've had this conversation with camps as well, there is an economic aspect of this, right? Because if you keep the schools closed, it makes it harder for people to go back to work. And if people are going back to work, what do they do with their kids? So again, all of these things sort of feed into each other and make the decision-making difficult, right? And again, to layer on another issue, right? I think part of the whole process for doing what we've been doing in terms of the economic shutdown was to flatten that curve, keep things lower so we don't overwhelm the health system. So we've done that effectively. The question is now sort of what's the end game and how do we get out of that? And part of that depends on what is the future likely to hold, right? If we were to be able to say in August, we're going to have a vaccine, I think that changes your decision-making process, right? Whereas if you're going to say we're not going to have a vaccine for a year and a half, well, then that's a different decision-making process, right? Because if the vaccine's coming in August, when we can say, well, then it makes actually more sense to keep things shut down more because you can save a lot more lives. But if it's going to be a year and a half, then it makes it a much more difficult process, right? And so, I mean, historically, there isn't a really strong reason to believe we would have a vaccine by September, but you know, there was also no one thought we were going to shut down the entire economy like 2.5 months ago. So who knows, right? But I think that the evidence, at least right now, despite some positive news, is that there's probably unlikely to be a vaccine this year, and that we should probably proceed at least on those grounds at the moment.
So to follow that up, and it was going to be a separate question, but you went right into it.
Sure.
You think that there's a reasonably good chance in 2020 that there's a vaccine available, or are we talking about 21 or 22?
I mean, so I will say that there have been reasonable gains made and reasonable progress made on developing vaccines to an extent that I did not think would have been possible 2 months ago. So again, you know, we don't know how things are going to play out, but there have been vaccines that have shown efficacy against this in monkeys, which is our closest analog. Now, again, just because it works in monkeys doesn't mean it will work in humans. And so there are something like 100+ labs working on this, and already several vaccine candidates in trials. Now, the difficult part is, even if, let's just say, so the prime example is the 2009 pandemic, right? Where the H1N1 pandemic, where they actually had, like, all they did was modify the vaccine that we normally get, and they had it ready by whatever, May, to start production. And yet most people didn't get that vaccine until October or November at the earliest, just because of production, right? And so even if they had a vaccine ready today, it would still not be available widely for months, because it's just going to take a really long time to scale that up. And so I've actually been on a couple of calls where we start talking about the ethical guidelines of who gets those vaccines if you have a limited number of vaccines. And I'm not going to sort of weigh in on that, but there's definitely some issues around that. But so I would venture to guess that the likelihood of a vaccine in 2020 is probably lower than, I don't think I would bet on it, But I think that there's a chance that 2021 would see a vaccine.
Gotcha. So being closer to a monkey than most people, I should volunteer to get the test.
Well, there's actually a really interesting question, ethical question, because we don't do human challenge trials anymore, right? We haven't done them since the 40s probably, right? Where you would actually inoculate someone, then challenge them with the actual virus. And there's a question as to whether or not we should do that. And there is actually a list of people who have signed up to volunteer to do this. And I would probably venture to guess that you would not be accepted, given that you are, I don't mean to be disparaging, but you're older even than I am. So
I'm older than most people, so that's
so no, but seriously, like the goal would be to challenge it in people who are less likely to get really sick. Again, it's not clear whether or not in terms of the ethics of that, but that is one of the things that they actually are discussing.
Dr. Klein, we have
Yes.
several questions from our audience that I'd like to ask you.
Sure.
So the first one is a question from a viewer here on Zoom. What is the risk level if I met friends on a screened porch and we have dinner about 10 feet apart, no one is symptomatic or had been exposed that they know of? So really, they're looking for some advice here.
Sure. So, I mean, these are obviously, we all want to know, right? What's the risk? I mean, I think that there's two issues, right? The first is that generally most transmission events have occurred indoors. And because indoors there is a closed, whether it's in an office building with sort of closed air handling or a smaller room where the virus can spread in the air and be transmitted in the air. And so being in a enclosed space, and the smaller that space is, the worse it is. Being outside is definitely a better, and that lowers your risk. The aerosolization of the virus seems to be, there's differing studies on this, and part of it becomes how infected you are at the time, at that moment. And so just because somebody isn't symptomatic does not make them not infectious. And in fact, they're probably most infectious just before they become really symptomatic. That said, there are also people who are completely asymptomatic who have been shown to be transmissible. So I think, obviously a general guideline is if you are feeling sick and you have any type of symptom, and particularly some of these minor symptoms, not just fever, that you should avoid contact with other people. But, is the risk somewhat, I would imagine the risk is quite low in the situation that they're describing. Again, it might depend in part on where that food came from. So if it's one person preparing it, I'd be a little bit more concerned than if it was brought in from outside or like from a restaurant where they are taking precautions like wearing masks and gloves, or if everyone's bringing their own food, then that's sort of the best situation.
So I have a few more questions. Now you're getting very popular tonight. So from Liz here on Zoom, how far along are we with finding a treatment versus a vaccine?
So I don't know that there has been any very good treatments. There has been, was it remdesivir, which has shown some efficacy in people who are very sick. Trials are still ongoing. I think one of the bigger things that has been discovered, though, is actually more management of disease rather than just treatment. And so early on, particularly in New York, where you had things being overwhelmed, there wasn't quite as clear an understanding about how to manage people who were very sick. And now I think that there has been a shift in that and how those people are managed, particularly around the use of ventilators. So people are going on ventilators much later now. And there's also this recognition that for whatever reason, the virus seems to be causing blood clots. And so anti-blood clotting medication in patients who are very severe. So I'm not suggesting anyone should go out and take anti-blood clotting medication, that it seems to be one of those effective things that is keeping people from getting from real morbidity and mortality in those cases. So I think in general, mortality will probably come down somewhat, in part as well, in New York, the mortality rate is probably going to have been higher because the hospitals were somewhat overwhelmed, and you had people working in the ICUs that don't normally work in the ICUs. And so management of patients was less. So I think there's been more management of cases than there have been therapies specifically.
Interesting. So here's a real crystal ball question for you.
Okay.
So someone would like to know if it is too risky to go to a wedding in late October.
Yeah.
Wedding in late October.
How about that?
I mean, I guess it'll depend on where the wedding is. I think we have one in November, so I'm not really sure. So I think there's, again, the questions will really come down to how much of a fall surge we have and where that surge is happening, right? And so I think, so one of the things that's going to happen most likely over the next couple of months, and I'm starting to see the data on this, is that places like the big cities have stayed generally locked down. Even in the southern states where they've sort of started to open up, movement in those cities has not been nearly as great as it was. It hasn't come anywhere near where it was before. However, the more rural areas of the country have actually had movement data that suggests that there are much greater movement and less social distancing going on in those places. And surprisingly, I didn't actually even realize how great of an extent it was. 70% of counties in the US have a population of less than 100 people per square mile. For context, Baltimore is something like a couple thousand per square mile. So there's just vast differences between parts of the country, and which means that those rural areas, it's going to be spreading slower, but they're not actually locking down much anymore. And you're actually starting to see increases in some of those places. Unfortunately, unlike New York, it's not going to generate huge numbers of cases. It's going to be small numbers, like in little places, which in aggregate will turn into a large number. But because it won't be any one large number at one time, it's going to be a large number of people that will get infected without really becoming the crisis that it probably should. So when I say where is the wedding, that is actually an important question, because if it's in New York City, that's a different question than if it's in a smaller, more rural part of the country.
So I have two camp questions for you. Parents are very eager to know what they should do with their children for camp. Should they send them to camp? Should they not? One questioner on Zoom said that their summer camps decided to open. And is it a safe environment for kids if they're doing all they can to mitigate the risk, testing, social distancing? Any thoughts on that?
Yeah, so I've actually been on several different camp advisory health boards, I guess, whatever you want to call them. I'm helping trying to determine these things. It's a difficult question because I think I don't actually, again, because the Kawasaki illness is an issue, but in general, the kids are not getting tremendously sick. And so the question is, what is the risk, right? And the risk is largely, so there's two issues that we've discussed. One is we don't know if there's a dose response to this, right? So most kids would not be in very close contact in general with other kids. Even in school, you're not gonna be like super, super close. But if you're in, say, an overnight camp and you're sleeping in a bed or a bunk bed even, I'd be really worried about a dose response issue where somebody's getting very sick and they're like 3 feet away from somebody else for an entire night. That we don't know if there's any issue there. But in general, I mean, I actually kind of joked initially when this happened that we should send all the kids away to summer camp, first of all, so that they can all get infected because they don't really get sick, and then they'll come back and they'll be, help us provide herd immunity because you can open the schools. So I think part of those issues though is that the kids, while they might not be at significant risk, all the counselors would be at risk, and any community outside of that camp would be at risk. So it's sort of it's not like the risks are variable, right? And I think it's partly a societal risk and partly a risk that the kid goes, if you bring a lot of kids from all over the country to one place and then send them back, that could basically be the seed for spreading it around the country. So again, there's issues to consider there for overnight camps. For day camps, it's what we've sort of suggested is that they don't really call it camp, because it's going to be really hard to run camp the way people think about camp. I realize that people need to go, some people are going to have to go back to work, and having daycare or childcare is a real issue. I realize this is a tremendous hardship, and it's a mentally taxing on us who have our kids around all the time. I think it's really hard for the kids socially. And I think the risk probably is again, not so great for the kids, but one of the issues will be, depending on how the state here implements quarantine and testing, would be that if you send your kid to camp, and I believe the rules are going to be probably somewhere around the idea of trying to have pods of kids, so that if one of the kids tests positive, you only shut down that pod and not the whole camp, which probably something like that will happen with schools, or that will be the intent, would be that if you send your kid to camp, there's a chance that you could end up in like a 14-day quarantine because your kid, or that you'll need to get tested because someone in your kid's group got infected.
So do you have children? And if so, are you sending them to camp?
So I have an 8 and a 10-year-old, and currently we are not sending them to camp. That partly we have the circumstances where I can work from home, and my wife is a teacher, so she doesn't have to work this summer. Again, I don't think that there's going to be camp the way camp would exist. I think that if my kids were a little bit older and had been going to a sleepaway summer camp, and that summer camp was opening, I would probably send them.
Gotcha. Let's go to the other end of the age spectrum, nursing homes. Half or more of the deaths in Pennsylvania, New York, other places are coming in the nursing homes. How is that curve, how is that model different than the general population?
So I will say that there's two issues here. One is that the nursing homes are a serious problem. I don't know what, I mean, there seems to be multiple problems going on in the nursing homes in terms of the spread within the nursing homes and the comorbidities of people who live in those nursing homes. And that's why partly the rates are going up, are very high. There's a third element of that, which actually is not talked about a lot, but it's been a particular issue here in Maryland, which is that some of those people who are getting very sick at the nursing homes are coming to the hospital and they have a DNI or a DNR. So they don't want to be intubated. And so would the intubation have saved their lives? Possibly, we don't know. But so some of the higher mortality rates from nursing homes, it's certainly not a good situation in the nursing homes. And clearly, when you look at the rates by age, the mortality rates for people over 75 or over 85 are scary, to the point where when my parents leave the house, I get mad at them. But what we don't really know, again, your point being that there's such a high rates in the nursing home, it's hard to separate from people who are 75 and healthy versus somebody who's 75 and has a lot of these comorbidities and may even be in hospice, right? So again, I think that there is I think there's still some questions there, but I think generally the risks have been consistent from country to country, that the older you are, the more likely you are to get severely sick, and the more likely you are to get hospitalized, and the more likely you are to die. And so again, I think that message has been drilled into people. And I think in any instance in where things are opening, I believe that most people who are older will likely be more cautious than people who are younger, which will have effects on what we see in terms of the curves, in terms of hospitalizations and mortality.
Very good.
So yeah. No, but again, the rates seem to be consistent even across, across gender. I'm sorry, there's a gender issue as well, but across race and ethnicities, it still seems to be that the rates are much higher and the risk is much higher when you're older. That said, I want to be very clear that the total number of people who have died or who have been hospitalized is actually greater in people who are under 75, right? The number is higher but rate-wise, it's a much lower number. And so the risk is much, much lower, but it's not zero. This is not the flu. It's much scarier than the flu.
What are the disparities by race and by gender?
So the gender one I'll start with first. It's not 100% clear, but it definitely is men. Men seem to be getting sicker and are more likely to end up hospitalized and are more likely to die. It's not huge, but it does seem to be some slightly higher. And nobody has come up, at least as far as I've been reading, with a great reason why. Because initially it was assumed that they were more likely to congregate or more likely to smoke, because that was what was coming out of China. But that has held true consistently across most of the country. So, most of the countries, and we're seeing that data here as well. So I don't have a good reason why, but that does seem to be the case. The race and ethnicity aspects are very disturbing, and it's not clear. I don't believe that it's any sort of biological or viral differences. I think it's largely around social factors. You're seeing this right now in particularly in Maryland. We're seeing it in the Hispanic communities, much more so than in even in the African American communities, in part because many of them are still working, and some of them are undocumented, which means they don't have any of the backstop capabilities, so they have to keep working. And many of them live in substandard housing, either large families in multi-generational families in small apartments, or in some cases, lots of workers together in sort of dormitory style housing, which that's the recipe for spreading it in a household type situation. And again, when you look at the rates by zip code, I mean, they just tend to cluster by the poorer, more less white neighborhoods, which generally tend to have more of these essential workers still working a lot.
And I have been telling myself that maybe I've already had a very mild case so that I wouldn't be scared to death to go out. But now that we're hearing that some people, I mean, at least these sailors, seem to have tested, that they were fine, they recovered, and now they're testing positive again. Is that a real worry?
So, I think so two things. One is, while we all want to tell ourselves that we possibly had it, myself included, I think the likelihood is that most of us have not had it, given the rates in Maryland. There was an anecdote somebody said was, if we told everybody that if you had it in the past, you were much more likely to die earlier, everyone would claim that the symptoms that they might have had before were nothing related to the COVID-related symptoms. So I think most of the, when it started to come into Maryland and when it was around the time that flu was still around and regular colds were still around, and most likely most people did not have it yet in Maryland. My estimate is somewhere around 5% of Maryland has had it, and it's going to be concentrated in areas that are not generally up here. That said, I'm not saying nobody's had it. I'm just saying that I think the numbers are fairly low relative to say New York or somewhere. The difficulty with people testing several times is that when these tests are not perfect, they're particularly susceptible to being false negatives. So what happens when you get infected is your viral load goes up, and then it'll slowly go down over time. But it'll fluctuate a lot from hour to hour and day to day. And so when you're very, very at your peak, it'll probably be very hard not to test positive. But when you're not at sort of the peak viral load, it's actually conceivable that you could test negative. So you can have very low levels of infection that take a while and persist for a little while, that don't really make you sick, but could potentially be transmissible. But you could imagine testing negative a couple times and then still testing positive. So I think the more likely scenario, so again, in every disease we see what's called the decay rate of infection, the time period of which most people will clear in a couple days. Some people, a small number of people will clear in a slightly longer time frame. A small number will clear in an even longer time frame. And then you get these really random people who take weeks and weeks to clear. And so you're going to hear about them because they're rare, and it's a big deal when that happens, right? But most people don't. That doesn't happen to.
Very good.
Dr. Klein, so I have two final audience questions for you before Scott and Beth begin to wrap things up. The first one is there more info as to why other organs are being attacked? More information.
I mean, I don't think so. I mean, I haven't seen anything. I think the most likely scenario and the most likely reason is that this is a novel disease. And so when it spread from animals to humans, it is not adapted fully to humans, right? And so an infection of the heart, which is bad, or an infection of the kidneys or one of those other places, those are unlikely to be transmissible infections, or very unlikely to be highly transmissible infections, right? And so those are sort of maladaptations for the virus, but because there's no real immune pressure at the moment, everyone's susceptible, those sorts of presentations might occur. I don't think that they're that common, but they are more common than we would have expected, than we're probably used to, because it's not a well-adapted virus for humans. And again, it may have been the way it spread in animals may have been slightly different, may not have been fully respiratory. Since it's the primary way that it's spreading right now is respiratory, you can imagine that as over time it will evolve to being primarily a respiratory spread virus in humans, and these extra cellular or these extra outside of the lungs and attacks on other parts of the body will be less and less likely. Will they go away completely? Probably not, but in general, I would imagine that once this has gone through the population once, even if it still continues to mutate and makes its return as a possible additional infection, it will not be, well, it will not be a pandemic again, because most people will have some level of protection. And the other is that it's probably not as likely to be quite nearly as virulent. And that's just sort of the common way that viruses adapt to humans.
Okay, so one final audience question here, Dr. Klein. So you mentioned that warm weather may curb the virus, but if warm weather is a factor, then why is it spreading in Florida and other warm climates?
Sure. So the issue is there's two factors. One is it's not just warm weather. So we have the flu spreads in Florida also, but it has a seasonal aspect in Florida as well. In the tropics, it doesn't have quite as much of a seasonal aspect, but even in the tropics, it will have some level of seasonality. The virus goes up and down. So why it does this is not 100% clear, but it's not 100% related to temperature. It has a combination with humidity, and there's some suggestion that it also has an association with sort of indoor environments and the dryness associated with those indoor environments. That tends to be much higher in the winter. There have of course been lots and lots of theories. There's no actually really good accepted reason why this is, but it's most, for the flu at least, it's most highly correlated with absolute humidity and not with temperature. So we are seeing tremendously bad outbreaks in places like Brazil. We're seeing tremendously bad outbreaks in parts of Florida, but the problem is that we don't have enough evidence yet to say whether or not it will dramatically change or just change a little bit or not change at all. My bet is that it will change some and the transmissibility will go down a little bit. And if for no other reason, then people will be outside a lot more. And so transmission will be a lot fewer indoor type interactions. And so that would account for some of it, and then potentially there is some level of reduced transmission. I do not believe that it will disappear, And I imagine that we will be in this sort of some phase of social distancing for quite a while.
Thank you. Scott, Beth?
Well, I got one basic message I think I'm hearing from you, is that there really is a pot of gold at the end of the rainbow. I don't mean quite like that, but there's some light, that there's a foreseeable chance of a vaccine. There's a likelihood of the virus itself mutating somewhat into a slightly different kind of disease, and that there's a chance of some herd immunity being created. So you seem to be looking at this as maybe not a disease that completely goes away, but moves out of the pandemic epidemic phase into being a sort of chronic thing that we see sometimes. Is that a fair statement?
Yeah, I think it is. I mean, I think there's two sort of the short-term issues, right? Which we talked some about, which is what is going to happen in July, August, September, or in October when you want to go to a wedding, and then what's going to happen, next year. And I think that in order for us to get through to next spring, I think by next spring, most of this will have gone to the point where we can get back to a complete normalcy or almost complete normalcy. But I think that for people who are older, getting back to normalcy is going to be much slower. So I would say, and I don't know who asked the wedding question, but if they were older, I would probably say I would be less inclined to go. If they were younger, there might be, I would say that the risk is a little bit lower. Again, the risk isn't zero, but again, I think that those factors are going to play into how this spreads and the impacts of that over time. I think in general, as long as we maintain some level of social distancing and keep things, and again, we're already returning to some level of normalcy, right? Some things are opening. What that level is and how quickly we get there will really change, will describe how much and how quickly the virus will come back. And I think that if we can maintain things at a lower enough level, the healthcare system won't get overwhelmed, and we can push things off and people won't get as infected, and that might allow more people to get to that point when you get to a vaccine or a therapy or your herd immunity, and you have fewer morbidity and mortality cases.
Very good.
I think you've just alluded to several of the things that I would have included in this. If you were in charge of the world, what should we be doing differently? Is there anything you would prescribe for us to do differently?
Well, I mean, obviously, people can take a lot of issue with things that have happened, and I'm not going to rehash most of that. But I think that right now, and the state seems to be doing a much better job of this, is that there's more and more testing going on. And the more testing there is, the more likely you're going to catch people who are pre-symptomatic or early phase symptomatic. And you're going to catch more people so that they don't spread it as much. And the more people that you can catch early on who don't spread it, the fewer people that get infected and the easier it is to have things return to normalcy while allowing for a lot of testing. So, I mean, I think that investments in quarantine and testing are the thing that I would do the most, and particularly in getting the speed at which you get testing and the speed at which testing gets turned around into contact tracing. Because what the models show is that if there's a long enough delay in that period, so if you, right now, most of the tests are taking 24 hours. And if it takes 24 hours for you to get tested, so you're not going to actually have shown up there until you're actually sick. So you've already probably infected several people. And if you then take another 24 hours till you actually get the test result back, and then probably at least another 24 hours till they start contact tracing, that's too long a period. So, if we can get these more rapid tests going that take, 30 minutes to an hour to result, and then immediately start contact tracing, that can make a dramatic difference. And so I think that's where investments can be made to try to really drop down the number of infections so that you can allow people to go out again and be, more normal in terms of their interactions with other people. And you can allow restaurants and you can allow things to open up.
Very good. Beth, I think First of all, Dr. Klein, thank you so much for being here today and doing this. I know Beth has some final comments that she wants to make. And again, we thank you. You've added a lot to the discussion in the community and raised the level of knowledge, and that's always helpful. So thank you so much.
I join with Scott in thanking you so much. This was definitely one of the most informative shows we've had. And I would encourage the people who are watching us live to tell your friends, because we certainly can be viewed after this. And I hope this will be recommended. Thank you so much. I know I learned a lot. So for everyone who's still watching, our next show will be Tuesday at noon. We hope you will join us then. If you are a healthcare worker out there, we want to also invite you to join the Associated's Maimonides Society. The Associated's Maimonides Society brings together dedicated healthcare professionals from all fields for industry-related programs held through a Jewish lens. You can learn more at associated.org/Maimonides. And remember to continue to visit associated.org and jmoreliving.com for more information, stories, resources, and stay well.
Thank you all. Have a good night, everyone.